Thanks, Georgina and Beck. While I ask the rest of the panel to come and join us on stage and check their microphones, are there any immediate questions for Beck and Georgina? We have one on the left here. So,
thank you all for great presentations.
come up on the stage, please.
I think something that's already been raised here today is really having a community of practice where, you know, there are a lot of people involved in immunisation. I think to improve uptake, we need all of us. It's really important, and it's great to see a pharmacist on the stage. But I'm just interested to know there is great representation from nurses here, which is fantastic, but really limited representation from pharmacists. And I think that's across a lot of the activities that, you know, the educational activities that we have, the conferences we have, and so on. And so I'm interested, how can we better involve pharmacists in our community of practice to make sure that in this really rapidly changing field, we're making sure that everyone gets the same opportunities for continuing education.
Am I on? I am.
Can I just answer that? So I'm Helen Stone, I'm from the Pharmaceutical Society. The reason why a lot of pharmacists aren't here is because they can't actually leave their pharmacies. They're out there doing it. So as the peak body for pharmacists, I'm here representing them, and the Pharmaceutical Society provides that education and that linkage through to the pharmacists. There are a small number of pharmacists here, but sadly being able to be here during business hours on a Friday is almost impossible.
It's an issue that also applies to general practitioners too, for them. Rodney.
Yeah, I'll take, I guess, the issue up to look at how some people are saying, think of us, look at us, whatever, but broaden it. So, and maybe talking about misinformation or disinformation, but when the Immunisation Coalition got various groups together to talk about some of our vaccine policies and who's going to do it, the standard problem that we've heard in the last 4 or 5 years is, if we talk to the GPs, it's the pharmacists aren't properly trained, they're just shopkeepers. The pharmacists say you can't get to see the GPs and always cost too much, and it's like, I think it's time for us all to start talking about when we can get a vaccine program. So to generalise the question, which is the challenge for all of us, I think, and listen to some of the answers. When does the flu season start, and when should we start a vaccination program? Now, the federal government will choose a date. It's usually about April the 18th. It might be the 19th, but they choose it just because they seem to like choosing it. The state governments choose when they start the flu program because they've had an outbreak and there's a nursing home or a whole lot of people getting sick. The pharmacists will start it because there's a national brand that gets the vaccines in early. The GPs will start it when they think they've got the stock or the private stock arrives. Australian vaccines are sometimes preferred, and there's a company that makes one in Australia, so they want to get theirs out early. So my question is to all of you, how do we go about making sure that we're all working together for something as simple as the launch of the flu vaccine season? So, Michael, do you want to start that, seeing as you'll fix it up for us next year? And then I'll look for other people's advice about trying to keep the misinformation and disinformation away so we can get a really good coordinated program. Thank you.
Am I on? I am, yes. Of course, there may be pharmacists and GPs who are dialing in with the 300 odd people who are joining us, so and hopefully watching afterwards as well. So I acknowledge all those folk. The easy thing is trying to work out when the flu season actually begins, because we have the national surveillance, and we've seen that happen over the last few weeks with the rising numbers. But as we know, influenza occurs throughout the year, and particularly with the very mobile population members of some of the members of our population travelling overseas during the Northern Hemisphere winter, bring influenza back, and so forth. The actual alignment as to when the vaccinations start depends on all those factors that were mentioned, Rod. And I'm not sure if there is a defined date, except, as you say, the Australian government will say now is the time that we recommend that people start getting their vaccine. One of the questions is whether you can get your vaccine too early and not be as protected throughout the season. I think that we've shown that that needs to be looked at closely as well.
We've got a couple of online questions and we curtailed them because of the interest of time, so I might just read a couple out. The first one, and it's probably directed to you, Michael, are there any plans to regulate social media platforms so that they can stop spreading misinformation? And I guess that's going to be a really big challenge.
So I think, as I mentioned during my presentation, this is much greater than just health. And there is this national coalition which is actually looking at this issue and looking at things that we can be doing as a nation. So I think we need to follow what that group is doing.
Can I add to that?
Go ahead.
I was also at that CSIRO National Coalition meeting, and this is something that comes up a fair bit as a sort of a knee-jerk reaction, this idea that we want to deplatform. And there is some evidence that that works when it's driven by the social media companies, so when they instituted things like the fact check, the community fact checks, or when they actually took certain super spreaders of misinformation, of whom RFK Jr. has been identified as one, that when they took them off of the platforms, it's clearly not going in that direction anymore. They've gone the other way. And at this point, from a government perspective, my personal opinion aligns with that of Liam Mannix. If anyone saw his talk at the CDIC this week, he's a science journalist, and he says, that the censorship idea doesn't really work that well. And so the idea of taking down individual pieces of misinformation sort of perpetuates this idea of conspiracy, this idea of, not being able to have that robust discussion about things. It's unclear who gets to decide what is misinformation and what isn't. So rather than hoping that these private companies can be legislated into some sort of action from likely a country that, where they're not based, I think we have to focus our efforts much more on various types of interventions to improve resilience to misinformation and alternative ways of sharing and building trust in true information.
Thanks, Jessica. I'll take one more from online and then we'll come back to the room. Ian Barr asks, how can we improve vaccination rates in nursing homes? We don't have Michael on the panel, but I'm sure whatever comment comes from the panel, Michael will probably have a rejoinder. So panel first, anyone want to take on that one?
Well, I think one of the ways is that we have an increasing number of pharmacists working within aged care facilities these days, so aged care on-site pharmacists. And many of them do have the accreditation to be able to immunise patients. So I do know of pharmacists who, when they're consulting with patients, looking at their medications, are actually looking at their air history as well and organising to actually vaccinate at that time as well. So I think that that's another way that pharmacists can contribute in that space.
And nurses, right? There's quite a lot of nurses that could be accredited or that are accredited that aren't able to currently practice in that scope. So I think expanding scope of practice would help.
And we have had since early in the pandemic the requirement that each of our residential aged care facilities has a nurse who's identified as the lead for infection prevention and control. Now, the people in those positions have been doing a fantastic job in identifying and responding to outbreaks of infectious diseases, both respiratory and gastrointestinal diseases, as Michael was describing. I think that David Laffin might want to talk about this further, but the new legislation which is coming in later in the year for aged care facilities, I think is going to actually strengthen, David, the requirement of those people in those positions to be involved in this sort of work as well.
I might ask Michael, do you want to make a comment about that? Because this is something that could have really come up in your session as well, and you have a very good on-the-ground feel for it.
If you looked at the data I showed you, most of those were from the same provider with the same policies and the same central command and control and hugely different rates. And you've got to think to yourself, well, which I put the question to the CEO, why is this so? And it's almost always because of key individuals. And I think we under-recognise the value of the individual. And there is no doubt, if we ask somebody about their experience in residential care, they will talk about people, not things. And it's always, oh my God, they've got a great CEO. Oh my God, there's a really great nurse. Or oh my God, the PSAs, when they're the sort of people who sit beside mum and spend that extra hour. And sure, the room may not be quite as clean as perfection, but quite frankly, who cares? That's what counts. So time and time again, I'm seeing it, the people. Now, sometimes that's the pharmacist, sometimes that's the GP, sometimes that's the leadership of the CEO or the key clinical nurse. And it's building that resilience, for me, is the thing that makes the difference, and finding out who your key stakeholders are.
So one quick question we've heard, as Michael was saying, that there is a requirement for a nurse to be in all of the aged care facilities. Do we know what proportion of those have actually been fulfilled? And is their workload 100% or is it 180% in terms of all the things they're doing?
Just here can Michael get himself into trouble yet again. Look, I think we've set the bar too high. We've made the education challenge excessive. I think that we've got a fantastic model with really brilliant people, but we've got a model that's great for hospitals and less good for residential care. Now, I know my colleagues don't all agree with that, but it's a hard bar. And we've got people who have got 6 jobs, because that's what happens in a single residential care facility, and this is just one of their other roles. And when you're faced by, there's a water leak, or Mrs. Smith's acutely unwell, or something, that always pushes everything else to the back, just like in the rest of our lives. So I think that, it is a fantastic first step. I absolutely agree. It is very difficult to maintain, particularly in rural and regional, e.g. Victoria, especially if there's a local hospital and you are competing for staff. Things are getting better because we've got more staff coming online and the turnover is dropping, but there are lots of challenges when you have great expectations and people are human.
And so as our discussion, I think it's what we call a wicked problem, which I had explained to me by 2 of my GP colleagues, is that there are no simple solutions, but Michael suggested one of the strategies of getting lots of people in the room, and normally when people are bouncing off each other, there's often some common ground where you can do a lot of...
And I think public health have got to step up more, acute health have got to step up more and be, part of the supports for the regional residential care facilities. And I think that because of the public hospitals under state, federal and federal government responsible for community, this is a little bit of a challenge and it requires sort of ongoing push. But, I should be expected in my division to look after and support the residential care facilities in my region. And I think that's not an unreasonable expectation.
Okay, we might move on to the room. You've been very patiently waiting.
Can you hear me?
Yeah,
Because
we can.
I'm a little bit short to reach the mic. So.
No, we can hear you well.
Okay, my name is Zara and I'm a biostatistician and data analyst at Aspirin. So in my community, there is a lot of misinformation regarding vaccination. First of all, it's because a lot of people in my community, they are migrant, and secondly, most of the parents, they cannot speak English. They do not watch English television, news, or social media, but of course, they watch a lot of YouTube videos, which is in our language. Sometimes it's concerning for me that I watch this, especially like in gatherings, these women, they talk about vaccine hesitancy. They discourage other women that do not get vaccinated because like some of them had a bad experience or whatever. And I cannot do anything about it. And it is also concerning for me that I cannot convince my mother to get vaccinated because sometimes one woman becomes the doctor for another woman in my community, and I'm sure this is happening in a lot of other communities as well because Australia is made of diverse communities. So my question is from Mike that what steps are the department taking to reach culturally diverse communities with the accurate vaccine information, and how as a local we can help to be part of this process, because I'm a little bit concerned attending this conference, so I would be great to hear.
Who'd like to pick up that one?
I can go first. I can't tell you what the department is doing necessarily yet, but I think what you're flagging is really important, and we're definitely aware of it. And an approach that I mentioned is effective but difficult to scale is this community engagement approach. So I do a lot of work on a program called the Vaccine Champions Program, and we've worked in various countries in the Pacific and the Asian Pacific region, and we go into those communities and we identify people who already have sort of that trusted position in the community, and we train them and we give them more information and we give them skills around how to have these conversations, because it is something you have to be trained to do. It's not easy to have a conversation that actually might change someone's mind. There's some evidence behind it and it takes a lot of practice. And so we go in and we train vaccine champions, and then we get them to go back into their communities and have conversations or run sessions or in other ways advocate for vaccines. Now, I guess the challenge is that that's pretty resource intensive. It requires time, it requires money, and it requires some consistency. And so I actually, not to put it back on you, but I would love to know, the government's really flagged that community engagement is a key part of their immunisation strategy, and they did invest in this during COVID, and then it dissolved. So there were all of these efforts to engage with multicultural communities and train champions, and we ran out of money. And so I would love to see that sort of sustained, continuous, consistent investment in those links into those communities, because I think that's the solution.
Without having another pandemic to drive it.
Well, yeah, ideally.
Michael.
Yeah, it's a great question and really, really important. And you're quite right. We learned a lot about this during the COVID-19 pandemic. The initial response was, well, let's get information out in 84 different languages. That didn't meet the needs. When we started to actually meet the needs was when we brought the communities into the Department of Health. We had the Federation of Ethnic Community Councils of Australia and many other groups which were providing very active advice on how to reach out, how to engage with local champions, how to engage with the people who are having influence, how to work. I did lots of interviews with media in many different languages. I didn't speak those languages. I was translated into those languages. It was fascinating work with SBS and many different language groups. I went out and talked to different groups who knew that here in the north of Adelaide we have a very large Burundi community, people who've come from Burundi in Africa, and I had the opportunity to go up and talk with that community. They brought everybody together to hear about what was happening, and with nursing homes or residential aged care facilities which were specifically focused and looking after different groups of non-English speaking background as well. So there were many strategies that we learned on. I noticed David Laffin is itching to say something from the department, so he'll probably tell us more about what's happening right now.
Oh, thanks very much, Michael. So I really think from the launch of the National Immunisation Strategy yesterday by the Minister, that further work, regardless of whether that is in, specifically looking at call communities or really the full range of implementation activities that need to support the launch of that plan, is something that we're going to be looking really closely at over the course of the next few months. We'll be engaging with experts, we'll be engaging with different people and communities and representatives of other communities in terms of the full development of that plan. So that is essentially my responsibility within the department. So I'm the Assistant Secretary for Access and Engagement for Immunisation. So essentially I have responsibility for access programs like things that happen through the NIP VIP, PHNs, the COVID program, and broadly the National Immunisation Program. I have responsibility for engagement, so all communication activities and campaigns that are run by the department. And I'm also the freshly, just in over the course of the last 4 weeks or so, I'm now the air data steward. So I have the full range, if you like, of things that were really kind of highlighted by the Minister as things he was interested in terms of the implementation. So that I have got a very busy 6 months coming up going forward while crafting all of those. While I have the microphone, I just wanted to add for Michael's question earlier in relation to residential aged care and some of the changing situation there. Firstly, the department was particularly concerned, and we've been talking to the Aged Care Quality and Safety Commission about a range of vaccination rates in different homes around the country. When we had a look at some of the data earlier this year, there was over sort of 500 residential aged care homes that had a COVID vaccination rate of less than 10%. And so we're feeding that data through to the Quality and Safety Commission to actually take some action in relation to that. It's great to see that the COVID vaccination rates in aged care have lifted when compared to last year, but they're generally not quite where they should be. In relation to the regulatory environment, the current state for the Quality and Safety Commission. I realise I'm probably slightly out of my lane here, but they're looking at vaccination through the lens of the quality standards, the existing quality care standards that are in aged care. From the 1st of November, when the new Act comes into effect, there's a new rule in there that requires that as a condition of the registration, so the new accreditation processes for aged care homes, that all residents and staff are offered the respiratory vaccines, and all residents are offered the NIP vaccines that they might be eligible for. So it goes from something to do in relation to the clinical care standards, and it moves into a requirement of an aged care home's registration.
Okay, we're eating into afternoon tea time, which reflects on my inability to keep everybody on time. But I'd like to do a couple of speed dating questions, which means you get a one-word or one-sentence answer, and they come up in the pharmacy area. So that, is there a fee for pharmacists to get the vaccine, and do they run a recall system? Very briefly, please.
For NIP, no, there's no charge. For private vaccines, yes, there'll be a charge. And yes, they can do a recall system.
And cold train training and CPR and other sorts of things? What happens
Absolutely covered.
Right.
Do you get paid for the vaccine?
The patient will pay for the vaccine if it's a private vaccine. If it's
You, as a pharmacist?
it depends on where you're working, I guess.
Okay. I think we're going to wrap up now because we've gone a little bit into afternoon tea time. I'd like everyone to give a warm round of applause for our panel. We have a view from the other Oval Office down to cutting-edge research about vaccines and from the front line, and we've done it in a truly democratic and Australian manner that has given everybody a chance to have a say, and no one's going to be excluded from coming here because of their comments. So thanks, everybody. Enjoy your afternoon tea.